talk a little bit about an introduction to EUS, and really amongst the scopes that you all will likely be using, the linear array echo endoscope is the one that allows for therapeutic maneuvers, and is by and large becoming the one that we are mostly gravitating towards. So given the brevity of the talk, we'll focus primarily on the linear array. So we'll talk a little bit about introduction to imaging. We'll talk about the instruments that you can use through the scope. And then we may break the talk for a short while and come back to different imaging stations and talk about structures that you would otherwise see around the luminal foregut or the upper GI tract. So just as a way of introduction, and many of you already are familiar with a lot of this, so I'll keep it very brief. The two basic types of scopes that you will use are a linear array echo endoscope. Let me see if I can get a pointer. Right there. Okay. So a linear array echo endoscope and a radial echo endoscope, and the principal difference between the two of these is the type of imaging that they allow you to obtain from the GI tract. The linear array is really a sort of a fanning type of image, with the transducer giving you sort of about a 90-degree view of luminal structures. Like a fan, think about the hand looking around the lumen, as opposed to the radial echo endoscope that gives you something that is more like a CT scan. So it gives you truly circumferential imaging around the transducer, and it's something that most of us can relate to easily. So the one that we'll be primarily talking about is the linear scope. But just to see the difference, here on the top is the radial echo endoscope, and as you can see, that dark structure smack in the center is the transducer. It basically radiates or emits ultrasound sort of waves in all directions around it. And based on differences in echo impedance of structures that surround the transducer, you then can see sort of differences in, or appreciate differences in pixel density, or how dark or light a structure is. What we primarily are looking for is echo interfaces. So if I were to point out an echo interface here, it would be this white one. So you see a little white line that surrounds this darker space in between, and that's an echo interface. And so we'll be talking a lot more about this as we move forward. A linear scope, on the other hand, has the transducer with, again, a fan type radiation of ultrasound waves that emit from there. And what it does is it gives you a similar ultrasound type imaging, except the imaging is sort of is focal and limited. Now, just to sort of delineate structures here, we may not have an opportunity later on, but here you see the transducer, and is the pointer projecting? Yeah. So in general, when you're looking at luminal structures, depending on where you are in the lumen, the one structure that you want to look for always that will allow you to orient is the muscularis propria. And in general, muscle appears to be black on endosonography. So the first outer black layer that you see is the MP, and there's an inner black layer that we'll come to in a bit, that is the muscularis mucosa. Now, most of us are gastroenterologists, and so just having an understanding of how different structures appear on EUS allows us to speculate as to what they are principally made of. And so we start by defining how black or white a structure is, put plainly. And based on that, we call or define something as being hyperechoic, meaning that it's white as compared to structures around it. And here you see calcifications that are pericentric within a lesion, so they're white or hyperechoic compared to the surrounding. You see a hypoechoic lesion, which is a black lesion when compared to everything around it. And you can see what's called an isoechoic lesion that typically is not something you would pick up in and of itself, but you would be able to identify what it's doing to structures around it by mass effect and deviating structures around it, and that there is an isoechoic lesion. Cancers typically are hypoechoic, like this adenocarcinoma, whereas islet cell tumors, as an example, typically are isoechoic lesions. And so just being able to tell that difference allows you to speculate as to what you're dealing with. Anechoic structures, meaning that they look completely black, typically are structures that carry within them a fluid medium. Now, a common question that we get asked is, well, this looks just as black as the previous structure, and so how do you tell the difference between a fluid-containing black structure or a solid black structure? And what you're looking at, the telltale sign here, is this area beyond that black structure. So if you notice, if I were to draw straight lines coming out from this transducer, the lines in this area and the way that this looks, it's blacker, it's darker than if I were to draw a line here coming out from the transducer and everything under it, right? This looks a little more white than most of this does. That typically tells you that there is something within this lesion that is increasing the transmission of ultrasound waves, and this is called acoustic enhancement. So looking at what is below a black structure will tell you what the structure is made of. It's not the blackness of the structure itself. So this, for example, is a gallbladder. I know it contains liquid. I know there's acoustic enhancement under it that looks like a cone. This, as another example, is the aorta. And here you're seeing a pancreatic cyst with a little bit of mud-type material under it. Now, when we're talking about mud-type material, it's important to see gravitatiously where this is sitting. The reason this becomes important sometimes is in the gallbladder, where you're seeing this mud-type material or something that forms a little ball-type structure, and you need to tell whether this is something that's adherent to the wall of the gallbladder or something that is mobile within. And so what you do is you can agitate the gallbladder, just move it around, and you start seeing this material rattle around the gallbladder, and that typically tells you it's more sludge than something like soft tissue growth within it. So we spoke about transmission of ultrasound waves, and the other sort of telltale sign that you would want to look for is the one we're looking at here. So what you see is a black structure beyond the transducer, and what we see below it is this white area that looks sort of brighter than most of the tissue around it. But then there are these two lesions within that dark sort of structure there that emit this black conical structure beyond it. So what that tells us is that these two structures within that fluid-containing duct are somehow obstructing the transmission of ultrasound waves, and that's leading to this darker area. This is called an echo shadow, and it tends to be cast by things that are denser than their surrounding medium. And so this is a typical appearance of a stone. The stone looks bright, and yet it casts a dark shadow behind it. This is not something you would see with a soft tissue lesion that may also appear bright, but would not cast that shadow. Now, as you sort of start using EUS, you'll notice that there are settings that you can play with on the console. Just as a rule of thumb, or if you were to remember 2 points and 2 points alone, it's that high frequency scanning generally gives you a higher resolution, but gives you decreased penetration from the transducer. So if the structure that you're looking for or want to evaluate with the EUS is located far away from your transducer, that's not the setting you want to use. This is the setting that you use to evaluate the walls of the GI tract, because it gives you very high resolution imaging of structures that are typically within a centimeter or two of the transducer. So it's used for things like staging of cancers, evaluating the walls, telling exactly where a lesion is coming from, those type of things. On the other hand, low frequency scanning typically gives you lower resolution, so you're not seeing the fine detail that you would otherwise expect from high resolution imaging, but it allows you to see structures that are located further away from your transducer. So let's say you want to see a lymph node that's located 5 centimeters from where you are. the type of frequency you want to set it at is low frequency. So those are the two things that you typically want to sort of understand here. Now, you know, different echo endoscopes are made differently. This is a Pentax echo endoscope. The general constitution is quite similar. So here you see the transducer. This is what contains those crystalloid thesio, the elements that emit the ultrasound waves. Your scanning occurs in a linear fashion away from here. And the most important part here is this therapeutic channel. So it's a channel that extends down from the scope that you're holding and allows you to pass instruments down within the field of scanning. So you can tell exactly where your needle is going when it's outside of the luminal structures. And that allows you to procure tissue like an FNA or an FNB, or to conduct therapeutic maneuvers like placing a lumen opposing stent and what have you. The other key factor that you all will see during the course is that unlike a forward viewing scope where your field of vision or your optics look in an anterior direction, with an EUS scope, much like a duodenoscope, your optics are off to the side, meaning that what you are seeing is not where your scope is going. And so as a general rule of thumb, if you're seeing it, you're not moving in that direction. And this is a concept that we'll go through again and again as we are moving through the course. Now, I'll quickly move forward with this. Now, these are just different instruments that, you know, we'll talk about. Here is a compatible sort of a central unit that you use to convert those ultrasound waves to an image. There are different ones. Here we use the Olympus. And I'll quickly come to imaging stations. Do you want to do biology? Go ahead.
Yeah, we can go ahead and do the stations, and then I will do some practical things.
ठीक है जी.
You can go through this.
Okay, so we'll just briefly go over sort of the anatomy of what you would expect to see as you're passing the scope down the mouth into the esophagus. So stations are sort of a just a basic understanding that you know, is an older thought process, I want to say, but does a fairly good job at just giving you an understanding of what to and not to expect as you're imaging an area. So the first area that you want to look at as you're passing your echo endoscope down is the superior mediastinum. The second area is the true mediastinum, and the esophagus is located more posteriorly. And the third area is at the EG junction. And typical structures that would help you identify where you are at is if you're at station 1, look for the aortic arch. And we'll look at those stations again today and try and figure out how to look at these. In the mid-esophagus, look for the left atrium and the aorta, and our goal will be to identify all of this through the day, through the course. At the EG junction, you want to look for the liver, and you want to look for the aorta with the IVC. So those are the three structures that you want to look for in that area. Now, this is a typical appearance of the aortic notch as your transducer is located in that first station. Given the direction of scanning, which is conical, sort of emanating from that transducer, bear in mind that what you want to do is be able to rotate that transducer in 360 degrees. So it has to, in a conical sort of fashion, scan the entire superior mediastinum. And so it's not adequate to just put your scope down and look at just one image. You have to be able to rotate your scope at each station and get a circumferential view. So that there is the aortic arch. This is what the aorta looks like in the mid-esophagus. As you can sort of notice, the difference is quite significant. Up here, what you're looking at is a cross-sectional imaging of the aortic arch because of the direction that it traverses in. Here you have more linear appearance of the aorta. As you are sort of looking at this image, always keep in mind that the head is located at the part that is closest to you. The feet of the patient are located at the part that is furthest from you on the image. And so as you're introducing your scope down, you keep moving in the direction of the feet. Once you've identified the aortic arch, your transducer is looking posteriorly in the esophagus, and so what you have to do is torque your transducer anteriorly, and that gives you a view of the left atrium. Okay, so again, it's just moving your scope around and getting 360-degree sort of scans. Again, the orientation is head and feet. The second station, as you torque your scope towards the left side, towards the right side of the patient, what you start seeing is the azygous vein. On the left side is the hemiazygous vein. And these things become important in venous engorgement of the thorax, in injection of varices, where you're concerned that clots are extending up into the chest, or migration of material. So those are the little caveats that you want to look for. As we advance the scope more distally, what you start to notice visually is a sudden change in the color from a nice white pearl-like color to a redder color. And as you make that transition, it tells you that your transducer is now located within the stomach. And at that area, as you look superiorly, meaning towards the outer side of the patient, what you start to see is the liver. Okay? And great. So those are the stations of the chest and the mediastinum. Now, imaging of the esophageal wall is crucial in patients with cancers of the esophagus. One of the more common indications that we get for diagnostic EUS is preoperative staging. It determines how patients will do. Back in the day, we used to think it important to dilate up malignant strictures and have your scope pass through, and now there is data that suggests that if you cannot pass a scope down, that you're T3 or above, so you want to not dilate esophageal stricture. But here you are looking at a typical appearance of a cancer, and we'll go through the staging in a bit. Cancers typically appear dark, so black is not a good finding on EUS. Unfortunately, it's not only the cancer that appears dark, but the peritumoral inflammation as well. And so in patients that have undergone radiation, the sensitivity of EUS to diagnose true luminal malignancy significantly reduces. So if they send you somebody who's had chemo-RT of the chest and they say, hey, can you restage the patient, bear in mind that your imaging is not going to be as good. So what we notice here is that there is a dark area that starts immediately below your transducer. Dark is bad. I can tell you this is a patient that has not had chemo-RT, so we can truly rely on this imaging. The black layer on the outside is the one you want to focus on. That is the muscularis propria. And the echo interface that we spoke about is key to determining depth of penetration. So you want to use low frequency imaging that will allow you to get high resolution imaging here. And as you can see, this white line extends uniformly and separates this particular black area from the black area on the outside. And that tells us that this tumor is very unlikely to have invaded the muscle layer. Okay, so that's one important thing to look for. Fat is typically white. It's not a very good transmitter of ultrasound waves. This is another example of esophageal tumor. And as you can see here, there's a nice dark MP layer, and you want to get a look at that. There's a white echo interface that separates the two. There's a darker area that's closer to the transducer. And here you see a dark area that starts right at the transducer, but it extends all the way down to the muscularis propria. And so the question now is, how do you know that this involves the MP and stops over there, or does this go beyond the muscularis propria? So what do you guys think? If it's invading the white part, it means it's going down, and that's absolutely. So why do we think it's invading the white part? Is because we are seeing these darkish structures. They're called pseudopodia, false feet. that extend out from an otherwise uniform appearing dark area. Like if you look at this MP, it's nice and straight. This MP here, or invasion, has a very rough margin on the outside. So we know that the cancer is not only invaded into the muscle, but is invading beyond the muscle as well. This is sort of one more image of a mass, and so let's give this another shot. So what we're seeing is, and it's not a fair image because we don't have the wall layers here, but what we're seeing is a dark area that starts under the transducer. This here is probably the MP. We are seeing sort of darker areas or a rough margin on the outside, but what do you guys think about where this cancer is going or what it's involving? And I'm telling you, that's the liver. It could have been anything, but it's sort of marked out as a liver. So the question is this involving a structure that's adjacent to the GI lumen, or is it not? Because that would be crucially important. Yeah, so yes, it looks like this dark area is extending down here, and then somehow this white, nice differentiating plane gets very fuzzy, and you see dark going all the way through. Now these are older images. The newer imaging that you'll see is much more refined, but the concept is about the same. So I think we'll stop at this and maybe hand over to the next speaker and go over gastric station.
So I think if you can just finish the stations.
The stations?
Yeah, like
ठीक है जी, sure.
And then after that, I'll just have some practical things. And then we'll start.
Okay, so we'll go over the gastric stations. Just to reiterate, think about these as not something that you need to document on your reports. This is not essential. These stations were sort of defined early in our course of EUS to just give you an understanding of the periluminal structures and what you should and should not look for at a particular area. So the first part is where your transducer is located, about a centimeter or two beyond the EG junction. The second upper GI station is where you're about 4 or 5 centimeters further down, and the third is where you're almost touching the greater curvature of the stomach. Okay, so those are 3 areas that you want to sequentially sort of evaluate as you're passing your scope in. In the first area, you want to look for the liver and the IVC. You want to look for the aorta, and we'll go over those imagings. You want to look for the fundus in the second area, and we'll go over what structures there are over there, but primarily the celiac artery and the SMA. And in the third area, you want to look for the pancreas, and that will be the bulk of your referrals, will be evaluating the pancreas. So station 1, as we look anteriorly, what you see here is a dark structure that courses through what looks like liver otherwise. And so this is the IVC that's coursing through the liver. The head is located on the upper side. And so if you were to look here, you'll see the diaphragm separating this area and the right atrium upper here. As you move your scope a little more medially, you start to see the left lobe of the liver, and this is where the hepatic veins sort of start to dissipate, and you have uniform liver appearing. We'll go over that imaging. And this sort of area is important because when you have a pathological involvement of ligamentous structures in this area, the gastrohepatic ligament in particular, that is something you want to fend for when you're staging for gastric cancers, because it changes the staging. And that is a typical appearance of a malignant lymph node in an otherwise fatty looking gastrohepatic ligament. So this is the primary cancer up here, and this is a lymph node that's separated. So this is esophageal cancer. I won't dwell on this very long, just because we've gone through the basic principles. But again, over here, what you're seeing is sort of black involvement of all of the layers, but then you have nice separation of structures that are periluminal. This is a typical appearance of what a metastatic lesion would look like in the liver. So it's typically well circumscribed, it's more hypoechoic, and as you do more EUS, you'll train your eye to identify structures around that expansile growth that will be deviated. So we'll talk about that later. This is the appearance of ascites. It's critically important to tease this out in patients that you're staging for SUA 2 and above gastroesophageal cancer, because it completely changes the staging and renders them inoperable. So that is what ascites typically looks like. It's black, completely hypoechoic, and everything beyond it appears more white. If you notice, this area is whiter than this area. So that's that acoustic enhancement that we spoke about. Other structures that you want to train your eye to pick up is on endoscopy. If we looked at this image, you know, it's anyone's guess if that is a solid lesion underneath, or if in this case it's a vein. So you can't really tell until you stick down an echo endoscope. You throw a Doppler on and you say, hey, this is not something that I want to biopsy. This could be problematic. Okay. This is the typical appearance of a esophageal duplication cyst. As you can see, it's a cyst that's most frequently located in the extraluminal area. Usually contains debris, may not contain debris, but typically has wall layers associated with it. Now, unlike the first image where we had a bulge at the EG junction, here you see a bulge also. But bear in mind again that that bulge can mean a subepithelial benign appearing lesion like a submucosal fibroma. It can mean something more sinister or malignant like a large cyst, or it can mean a varix. And so EUS is a fantastic sort of test to tell the difference. Now, as you're moving your scope more distally, this is a structure that you want to identify, and we'll go over again in the course. And you'll be able to put together all these images once we're doing them in real time. But what you see here is the aorta, and the first artery to emanate that is large from the aorta. So you have your phrenics that will emanate. They are very small arteries. You don't typically see them. But as you're tracking your aorta and moving down, you come to a double barrel sign. So it's like a double barrel gun. This is the first barrel. That's typically your celiac artery that you track down and it trifurcates. And then right beneath it is the SMA. Now, a principal difference between arteries and veins is that arteries tend to be more uniform in caliber. So if you look at this, it looks like a tube. Veins, on the other hand, tend not to do that. Arteries have more hyperechoic walls, so they're more pronounced and thick. Veins don't have that. Veins are just black Doppler flow that's not really separated by anything that you can see on EUS. And those are the principal two differences that will allow you to tell make that distinction. If you're questioning anything, particularly when it concerns vascular involvement, throw on a power Doppler, and we'll go over that setting. It'll tell you or allow you to make the difference between an artery and a vein, pulsatile versus non-pulsatile, and even things like the portal vein and the hepatic veins. And we'll go over that also. So as you turn your scope more posteriorly, and I won't dwell on this too much, it's better done in real time. You come up on those on the celiac trunk, and moving a little laterally, you start to see sort of a fatty area with what looks like little dark almonds. So if you all are doing celiac plexus neurolysis or other things in this area that are interventional, you want to sort of be able to identify those structures. Again, this is just a little sort of a Doppler flow showing that there's more biphasic flow here that is consistent with an artery. So this here is a typical sort of appearance. It's a salt and pepper appearance of the pancreas. Train your eye to see this and identify it. It's not as evident here, but it'll be more evident as you scan. Is a little black dot at the center of it. That's the pancreatic duct. But what defines the pancreas are the splenic vein and the splenic artery that really mark the superior posterior border of the pancreas. So the way we emphasize this with our fellows is if you're ever lost within the abdomen and you don't know what you are looking at, try and find the portal vein. That is the one that will show you where the structures are, and we'll keep going over that through the course today. This is what the typical appearance of the spleen looks like, and unlike the liver, it's uniform, it's salt and pepper appearance also. and you don't see biliary radicals within it. You may see some blood vessels, but you don't see any bile ducts, and that's how you tell the difference. Sometimes the patients with splenomegaly and the liver, they can be overlaying each other, so learn to tell the difference between the echo texture of the two. Now, this is a normal. We've gone through all of the abnormal, but learning to identify this is essential to diagnostic EUS. So I'm going to point out to the dark structures, and let's talk about what they are. So the first one that is most easy to identify is the thick black dark structure that is located outside, the furthest structure that you can track down. So if I were to sort of look at a histological correlate, this is what the structure would be. So I'm putting my cursor here. Any takers? What is that? That's the MP layer, right? The muscularis propria. In this case, it's a little thin, and there are variations. In the esophagus, that can sometimes be the case. The next black structure, and that will allow you to orient, is usually what is a thinner black structure that's located closer to your transducer. Looking at the histological correlate, that is this structure, and it is the muscularis mucosa. The white sort of fibrous tissue rich structure that separates the stew is the submucosa, and the mucosa typically is the whitish structure that is closest to the transducer. This is all periluminal fat that typically surrounds the lumen. So we'll quickly transition to pancreatobiliary stations, and this is the one that you will be doing the most as you evaluate your pancreas. So if I were to choose one of the important ones in this area, it would be what's labeled as 1, which is where you've now introduced your scope down past the bulb of the duodenum, past the apex, into the second portion. You've reduced your scope, much like you would reduce a duodenoscope, and you now have a 45-degree view of the ampulla that looks exactly like it would on a duodenoscope. So once you get your transducer at this area, you do a maneuver called a kissing maneuver, which is you touch your transducer up to the ampulla, and this is vitally important. Air is a bad conductor of ultrasound waves. So if there is air located between your transducer and the luminal structure that you're looking to evaluate, you simply cannot evaluate that structure. So how do we get rid of that air? One easy way is you suction down, okay? The other way is to use a balloon. Some operators like to use it. I know Dr. Hassan likes to use it. I don't. It's just a matter of preference. Using a balloon. The other way is lavaging your lumen with water. So what you can do is just have your tech give you water to lavage the area, and as long as you have water that separates your transducer with the luminal structure that you want to evaluate, you'll have good echo penetrance and you can get a good view of that structure. Water is better than contact because contact deforms what you're looking at. Water does not deform what you're looking at. You run the risk of aspiration if it's an esophageal structure, and the duodenum not so much. So as you evaluate this area, the structures you're looking at are the uncinate process. You're evaluating the pancreatic duct. This is a very important. You can evaluate the pancreatic duct as it passes through the uncinate process and as it comes up to join with the dorsal pancreatic duct. And that's where you rule out a pancreas divisum if that's something you're looking for. The lower part of the bile duct is what you can evaluate here. The clinical caveat to this part is that the bile duct in the lowest part of the duodenum is fused to the periduodenal structures, meaning that if you were to do an interventional procedure like a rendezvous, let's say, the chance that you'll end up with a perforation because you are not bridging the peritoneum is very, very low. So if you're given a choice to intervene, this is the area to intervene in an area where you have a little bump of pancreas stuck to the duodenal wall, stuck to your bile duct. That is good. As you sort of bring your transducer up into the apex area, again you're evaluating this part of the pancreas, and this is where you see groove pancreatitis. Now that's that little groove of pancreas that's separated by the bile duct wall, the duodenal wall. It can sometimes give you the appearance of cancer. You FNA multiple times, it comes back benign. That could be groove pancreatitis. So that's a clinical caveat. What you're evaluating is most of the bile duct, sometimes the gallbladder, because the gallbladder sort of falls over the duodenal bulb, and so it's an excellent place to evaluate the gallbladder, and the cystic duct structures. The duodenal bulb is the place that you use to evaluate structures that are located above this area, which is typically the common hepatic duct, branching out into the intrahepatic ducts, the cystic artery that may alert you to the presence of, let's say, a vascular stricture in a post-transplant patient with attenuated flow. And these are little things that you want to look for. This is the least privileged area to do a transluminal maneuver unless you have no option. And the reason for that is that as you exit the duodenal bulb, you're bridging the lesser peritoneum. So the lesser omentum is a sac that's located behind, the upper part of the duodenum and the posterior wall of the stomach. And so if you were to do something like, let's say, an EUS BD, try and get a stent into the dilated bile duct, the chance of you having a leak dramatically increases as you ascend the bile duct. Okay, so you want to ideally get into the part that where the bile duct is just about entering the pancreas. So there's a suprapancreatic portion of the bile duct, there's an intrapancreatic portion of the bile duct, and that junction is where you have about 1 or 2 centimeters of peritoneal cover. And so that is the most ideal area to intervene when you want to, let's say, do something with that is therapeutic with the bile duct. Pancreatic venous anatomy. Back in the day, this used to be a big deal because we were staging pancreatic cancer. I suspect your pancreatic biliary surgeons will want you to do that, which is why we'll just go over, the basic anatomy of this. So as you see the hilum of the liver, and we learn how to identify this, there's one large vein that exits the liver and tracks or goes all the way down to the neck of the pancreas. That is where it turns into the confluence of the portal vein. If you were to learn how to identify just one structure within the abdomen, that is the one you want to learn, the confluence of the portal vein. Because when you come there, it's like a crossroad that never changes. You are always in the neck of the pancreas. If you pull your scope back and track the vein, no matter what you do and where you are, you will come to the hilum of the liver. If you track towards the spleen, and we'll learn how to do that, no matter what you do, you are tracking the splenic vein and your pancreas will be there. And if you want to evaluate things like the uncinate process, let's say in somebody that has Roux-en-Y anatomy where you cannot put your scope down here, then you learn to identify the superior mesenteric vein and track that all the way down. So that is your highway that you want to learn how to identify here. Another thing I'll point out is the splenic vein and the splenic artery. Mark the superior posterior border of the pancreas and you track it all the way down to the spleen. So again, we'll use that as a highway to sort of orient ourselves in 3 dimensions. Another thing I'll point out here is this is a posterior view of the duodenum, and no pancreatic evaluation is complete until you have evaluated this area. Okay, the most common area that endosonographers will miss cancers in is that uncinate process. So you have to identify it, and the way to identify it is to learn on every exam how to identify the splenic vein and the splenic artery, and we'll do that today. So you identify the splenic vein, the splenic artery, learn how to identify the IVC and the aorta, and those are cardinal structures that allow you to make sure that you are not missing a cancer here. The other area that cancers are very typically missed are in the torus part of the neck of the pancreas. So we tend to look at the neck and we track it to the tail, 2-minute exam, very quick, but we forget to find that confluence and introduce our scope about 1 centimeter or 2 and evaluate that bump of the pancreas that tends to develop cancers also. And that is the one that you will miss if you're hyper-focused on just station-based examinations. So these are just structures that you learn to identify in different stations. I won't dwell on these in the interest of time. These are best learned when we are doing the cases live, and we'll share these PowerPoints. We're happy to do that so that you can sort of refresh your memory as you're doing these stations. Again, learn to identify these key structures. I'll point out that when you do have a dilated bile duct, like in this patient, again look for what is behind the bile duct, and that is going to be key to preventing sort of inadvertent sticks of the bile duct. So many a times when you move on to therapeutic maneuvers, your trajectory of entry is going to be from here. So don't focus only on your target lesion, focus also on what is located behind it. And in this area in the duodenal bulb, you have the bile duct, and it's fantastic, it's a nice big target. But if you introduce your instrument further down, the structure that you're going to hit is the portal vein. And that is what you want to avoid. So you stick, let's say, a cautery enhanced stent, hit the posterior wall of the bile duct and penetrate into the portal vein, then you have trouble if it's located in that problematic area of the duodenohepatic ligament. You're going to have bleeding intraperitoneally, and that's a problem. So focus on surrounding structures around your target. That is vitally important. Learn to identify foreign bodies. These are very helpful. So a patient with a stent in the bile duct, you're trying to evaluate, is this a bile duct, is this an artery located in the area, oh, my Doppler is not working. Learn to identify what a stent looks like, and a stent looks like two little white dots with black inside. And those dots is what you can track up and down in the bile duct, and they help you sort of orient yourself. When you have a pancreatic stent, use that as a guide to evaluate the entire organ when you come across those patients. And we'll stop at that. Guys, any questions? Okay.
One question. You just mentioned about puncturing the portal vein or the artery. So between the vein and artery, if you were to puncture, what is more dangerous? The vein. Why is the vein more dangerous?
ये जो है ना, ये बड़ा ख़तरनाक है. ये there should be some वो इसको रोकने वाले. तो लैपटॉप इससे बड़े आराम से गिर जाएगा. देख रहे हो?